Hello, everyone. This is Chadi Alraies from Heart Trending. I'm really privileged to be with one of the presenters and highlights of ESC 2024 in London, Dr. Carlos Collet, to talk about a new evaluation and follow-up of physiology before PCI. Carlos, thanks for being with us.
Well, thank you for inviting me.
Yeah, and Carlos, let's start first with the background and hypothesis of the study.
Well, so basically, we're talking about FAME2. So FAME2, as you know, is one of the most important trials in the field of physiology. It has influenced the guidelines both in the US and Europe. And FAME2 has been published already 3 times in the New England Journal of Medicine. So we published the first publication in 2012, then the 2 years follow-up 2014, and the 5 years follow-up in 2018. So we basically decided to follow up the patients for 10 years. And this is what we just presented at ESC. So basically, is the 10 years follow-up of the classical FAME2, which show that guiding PCI with fractional flow reserve resulted in better outcomes than medical therapy alone.
Absolutely, yeah. So again, the same number, I'm assuming the same number of patients, but maybe the follow-up is long, so maybe we lost some patients. So how is the number of recruit?
So basically, just to kind of put the population also in context, because many people may not remember what was included in FAME2. So we're talking about stable patients with 1, 2, 3 vessel disease. These are randomized again to FFR or medical therapy. It's important to mention that patients with left main coronary stenosis, patients with acute presentation, and patients with indication for surgery were excluded. Okay, so we're talking about PCI patients, 1, 2, 3 vessel disease. And you are right. In FAME2, we had 28 sites, 888 patients. For the 10 years follow-up, we were able to reconsent patients in 16 hospitals, 3 in the United States, the rest in Europe. And we were able to reconsent 70% of the initial population. So we lost 30%. These long-term follow-ups sometimes are difficult to conduct, but we're very proud to have reached 70%.
Right. So before we dive into your result, can you remind the audience of what was the main highlight of FAME2?
So FAME2 basically was the first trial to demonstrate that clinical decision-making based on fractional flow reserve was better than medical therapy alone. So if you decide to do PCI based on a fractional flow reserve less than 0.8, that translated into better outcomes than not treating the patient with PCI, just basically manage those patients clinically. And that was kind of, again, 2012. That was a big trial. Goes in the same line of ischemia, but with a little bit more of invasive tools to better select the patients in that regard.
Yeah. So tell us what you found.
Well, let me tell you first what we did, because we kept the hypothesis. The hypothesis is that doing PCI guided by FFR is better than not doing PCI in patients with ischemia defined by fractional flow reserve. So that remained the same. But this time we apply a methodology that is called the win ratio. And the win ratio is quite interesting. I learned a lot while doing this with a statistician, because basically you take one patient from one arm and another patient from the other arm, and you compare them. And you compare them in a hierarchical way. So the first comparison was death. Are both patients alive? Okay, if both patients were alive, we call that a tie. So we go to the second level of hierarchy. The second level was myocardial infarction, and the third level was a revascularization. So we ended up with 200,000 pair comparisons. And then we used the data, all the data of the 70% that we have the 10 years follow-up and the 30% that we only have, let's say, the 5 years follow-up. And what did we learn? I'm going to tell you, let's say, the big headline of the study, and then I'm going to try to dissect how to interpret those numbers. So basically, at 10 years, when you look at the primary endpoint, which is a composite of death, MI, and urgent revascularization, it was significantly in favor of PCI, with a win ratio of 1.25. That basically means that patients that were treated with PCI had 25% higher likelihood of having better outcomes compared to those that were treated medically. Now, when you look at this win ratio analysis, you will see 3 things that are a bit unusual for the way that we look at trials. We're going to talk about how many times PCI won. So PCI won 29% of the time. Okay. Medical therapy won 23% of the time. And there were 48 patients that were ties. Okay, you say, okay, Carlos, what can I do with these numbers? Well, I'll tell you how I read that clinically. If you're a clinician and you have a patient with a low fractional flow reserve, well, in half of the cases, in 48% of the cases, it doesn't matter what you do. Basically, you can treat the patient conservatively or you can treat the patient invasively, and both will have the same outcome at 10 years, which is a lot to say. Now, this is, again, I believe that this approach helps a bit guiding practice to our colleagues, but there were two groups that benefited more from PCI than others. And this, we call that interaction testing. So when we look at the subgroup analysis, we see that patients with very low FFR, so less than 60, and those with very tight stenosis, those patients significantly did better than those that were treated with PCI than those treated medically. So what I would say is, in half of the cases, these were ties, but in those particular two scenarios, there is a clear benefit of PCI.
That's great. I mean, again, it's reassuring to see that happening at 10 years, which is this is what the patient worry about when we sit with them at the bedside or when we are trying to plan a procedure for them. In terms of medical therapy, I'm assuming you did some adjustment for medical therapy, but is there any comments about the medical therapy for either groups?
Well, basically, medical therapy was similar between the groups. So we have compared the amount, for example, there was guideline-directed medical therapy. So basically, all patients are on statins, all patients are on aspirin, and of course, the other risk factors were managed according to the guidelines. But there were no difference in terms of the medical therapy at 10 years. So that variable, let's say, was similar between the two groups.
Great. So in final one line, Carlos, if anybody listening to us has a stable ischemic heart disease patient, as you said, with multivessel, what would be the main implication of what you found?
So what we demonstrate now is that first, selecting the patients for PCI based on fractional flow reserve leads to better outcomes than treating the patients medically, and that this is basically driven by fewer revascularizations, a trend towards less myocardial infarction, but no impact in all-cause mortality. So again, this, in my view, validates basically the way we practice, where we see that there are some patients that really benefit from the procedure, and that, again, FFR continues to be one of the best tools to guide us on this decision-making.
Absolutely, totally agree. And thank you so much, really, for a very insightful and phenomenal analysis of 10 years follow-up. And congratulations for being at the ESC top picks or top trials. Really appreciate your time, Carlos. Congratulations, and hopefully I can see you on a different platform in the near future.
Thank you, Chadi, for inviting me.
Thank you. Have a good day.